Please remember to stay muted unless you are speaking. And if you have any questions, you can put them in the chat or you can raise your hand and we will get your question answered. So to begin with, I am very pleased to be able to introduce Dana Lazenby. Dana was formerly with Detroit Wayne Integrated Health Network as a clinical director, and she now joins OCHN as our new CEO. So join me in welcoming Dana.
Good morning, everyone. Very happy to be here. And as Deanna said, I am from Detroit Wayne Mental Health Authority, now Detroit Wayne Integrated Health Network. I was with Detroit Wayne for probably about 14 years, a little more, a little less, and various roles: utilization management, serving people with intellectual developmental disabilities. Let's see what else. Evidence-based medicine. Then I went into, again, utilization management was the biggest piece. And then moving into being a deputy COO and then acting COO. And within a matter of maybe a month, I was interim CEO. So right before Willie came on board to Detroit, I was in the interim role. Long history. I think one of the things that makes me somewhat unique is I am actually a limited licensed psychologist and I have a business degree. So good combination. I learned very early on. Clinical work is amazing, but if you can't manage the business, it's really hard to do the great clinical work that we do. And in saying that, I know I'm talking to service providers who provide residential care. And I do want to thank you all. I know it has been a really rough 6 months, and the challenges that you face and being able to maintain services are extremely important to the people we serve. So I do thank you. I hope that we are supporting you as much as possible. I was able on Friday to participate in the handing out of the PPE. I didn't do a lot of physical labor, I have to admit, but it gave me a good opportunity to meet more of the OCHN team because like you, we're working in a virtual environment, but you guys on this call are doing the hands-on work. So I do appreciate that, but I also appreciate the team we have here who is volunteering actually to drop off that PPE to you all, which I truly appreciate, and I know you do as well. The other thing, I know that we have some challenges, the challenges of maintaining a very highly trained, complex group of direct care service providers or direct care workers or professionals. I think that that is something that's very critical to OCHN and making sure that we have the support available so that we can encourage individuals who want to serve in that capacity to work with us. I saw an ad, I think it's this morning, with a home care company that was doing some recruiting. So I really think we have to network together and create some ways to encourage people to work with people we serve. And then we have to look at some things that are outside of the box. Is there a way to provide some in-home monitoring that people need that meets them where they are? So everybody may not need hands-on one-to-one services or people in their homes, but they may just need some additional supports and reminders. But I really think that that has to be our focus going forward. There's a lot of competition for us. When you think about Amazon and these other organizations or companies that are opening up, and the pay rate is very competitive, almost a no-brainer in some sense that people would choose to work there as opposed to working with people. So I know even in my own experience, working with people is very important, and you have to love what you do because we know that the financial reward is not always the greatest, but we have to do something to work on that and support the community. And even looking at ways to get the direct care professionals, support staff, training and certification that would allow us to pay them at a higher rate. So those are some of the things that I think are truly important. You will see from me, I do put people first, and everybody we serve, including the providers, including my team here at OCHN, is critical to what we do. We work together. We're open to feedback. I have an open door policy with my team. So any questions or concerns you have, I always will be open to listening. I know that we can't always agree on things, but we will work together to compromise where we can and come together and really put the people we serve first. So I'm always open to questions. So if anybody has anything that I may be able to answer, I'll do my very best to do that, either through this meeting or even in an email. So my email address and everything will be provided, and then you guys can send me an email if you have questions or concerns. And one of the things people are learning about me is that I am a people person. So if it were not for COVID-19, I actually would have been out and visiting the provider community. So I would love to be able to do that. And I am looking at ways that I can start to get out there and go to providers and go to the homes and meet people, because that's one of the things I love first and foremost. I love the clinical work, and I am very fortunate to be able to do both. And hopefully we can touch a lot of people and improve the quality of life. And I really want us to live by our mission internally and throughout the community. So thank you again for everything that you're doing. And please feel free to drop me a question or a comment, or if there's something you think we can do better. I love suggestions. So that's all I have. Thank you.
Thank you, Dana. It's great to have you as part of our team.
Thank
Does anyone have any questions for Dana before we move on to our next agenda item? I'm not seeing anything in the chat, but I'll give you a minute.
Mhm.
Okay, I did put Dana's email address in the chat, so
Thank
you
you.
can email her with any questions that you might think of later on today or tomorrow or anytime, right?
Yes, I'm going to hang out for a little while and listen in, so I'll be around. Thank you, everyone.
Thanks, Dana. So next up we have Adam Hamilton. Adam is the manager of the Provider Network team. Adam is going to review the FY21 Specialized Res and CLS Direct Service Contract. A couple things that I want to say before Adam gets started. This contract does not include the lease and maintenance language that some providers will be receiving. That is still in development. And then also, I had sent out a contract draft a few days ago. However, it was revised last night. So this morning on the YMLP, I sent out the revised copy. So it probably just 20 minutes before this meeting started. I don't know if you've received it. It had some minor changes, but Adam will go through those. Adam, take it away.
All right. I'm going to turn off my camera in a minute just to preserve bandwidth, but just want to say good morning to everybody. It's nice to be able to connect with you again here. I think what we'll do, we'll screen share the contract. I'm thinking we might be working on that at the moment. I've got a few bullet points of kind of some things that were maybe changed or would stand out to you in the contract. We'll go through my bullet points, but fundamentally, I think the time would be best spent answering any questions that you may have or doing our best to answer some questions that you may have. May be the case that other people have to chime in and provide some assistance with those questions, depending on what part of the contract they're coming from. So, we have some other team members from OCHN here who are going to be available to jump in if we can. Dina, if you could monitor the chat for questions, that would be extremely helpful. And we can always do kind of a compilation of the questions as well. So if we can maybe get those all written down and respond in writing, maybe we could send something out over YMLP after the meeting as well with the minutes. So that's an option if there are just a whole lot of questions. And if we need to do to follow up with folks internally to get you the best answers to those. So I think that's kind of the best approach at this point. Again, I'm going to turn my camera off just for preserving a little bandwidth here on my end so we can hopefully avoid any internet issues. And we'll go ahead and go forward. So there were some changes to the boilerplate. The first section of this pretty much is going to look very familiar, as there are not any major changes. If we go down to page 7, please. There's going to be a place indicating where the lease and maintenance language is going to go. This affects a subset of providers who know who they are already. There's going to be some additional details about that forthcoming and some additional correspondence coming out. So that will be discussed down the road. The item 3, if you could scroll down just a little bit here. The financial hardship language. So what this really does is it specifies or details a process for providers who are experiencing financial hardship to request assistance from OCHN, clarifies what information we would need to move forward in reviewing that request. And again, it kind of lays out the steps of what's going to happen there. So if we could go down probably all the way to the attachment A. This is where a lot of the big changes are going to be noticed. So that's page, I'm sorry, that's page, it was page 36 on the version I reviewed previously. I don't know what page, it's probably 35 or 36 in this version. Oh, yep, just back up a little bit, please. It looks like the top of that page. Yep. Okay. So in the attachment A, you'll see we have CLS rates with new modifiers. There is probably going to be some questions about this, and I think we're going to kind of get into that a little bit later in the meeting, although I'll just point it out here. Scroll down just a little bit, please. You'll notice that we have different rates for services provided 1 to 16 units per day and then 17 units per day plus. So we'll talk a little bit about that. The T2027, excuse me, is the new overnight health and safety monitoring code. This is a service that's available for individuals who are on HAB and children's and SED waiver. And modifiers associated with that. We included an explanation of how to use the modifier for when 1 to 16 units per day are provided and some parameters around the use of that modifier. And then there's some language about enhanced staffing exceptions. So this is something that many providers have dealt with already. We've just included some language in the attachment A this year when those requests are made for enhanced staffing. Some language about profit cap. If we keep scrolling down, please. These are the incentives that we had previously. We did not make any changes to these, so just be aware that those are still in the attachment A. We're still hoping to honor those. But remember, if you could scroll down just a little bit more, when we are in the alternative compensation method timeframe, incentives are not applicable. Keep scrolling, please. And of course, this is a new section. Oh, just up a little bit, I'm sorry. Up to the next heading. There we are. This is a new section of the attachment A that details the alternative compensation methodology, the process for that, and we can keep scrolling down. And if providers choose to opt out, what the process is for that as well. So you may recall that we switched from a fee-for-service payment methodology to this alternative compensation method during the COVID pandemic. This basically details what that's about, how that will work going forward. So we wanted to have it in the contract initially because obviously we're still trying to navigate through this pandemic, and the implications are being felt system-wide here. So it just made sense to include it at this stage. If we could go down to the next attachment of the contract. This is the attachment B. So this basically just lists the services that we're contracting for with your organizations. You'll notice that the CLS per diem code is no longer included here. The state is doing away with that, and thus we have some new modifiers and kind of a new methodology for authorizing and paying for CLS services. The overnight health and safety code shows up here. It specifies again that it's for individuals on the habilitation supports, children's, and SED, serious emotional disturbance waiver. So that is indicated here now. And then of course we have our licensed setting codes, personal care and CLS in a licensed setting. I think we have one additional code. Please feel free to keep scrolling there. This is the code that we've been utilizing when providers are supporting individuals who have no benefits in place to pay for room and board, or they've lost their benefits to pay for room and board. So we have a process for temporarily covering some of those expenses using general fund. This is the code, and there's a little bit of detail about what this is and how it works here. So as many as those of you who have utilized this may know, we have a process where a sports coordinator or case manager can request this support. We review it internally, and we approve those on a time limited basis, and then re-review if we have to. So that's essentially what this is talking about here. There's not too much I'm going to say about any of the other attachments. We'll talk a little bit about the attachment D, reporting, with emphasis on the financial reporting obligations a little bit later in the presentation. Victoria is prepared to talk about that with us. So I think the thing that I'd really like to spend some time covering is any questions that you all may have. So I'll kind of check in on the chat here for a moment. And then if people can, you feel free to unmute as well and just ask your questions. And if I can answer them, I will. If I have to get somebody to help me, I will check with the team who's on the call from OCHN as well. Looks like we have one question in the chat. Yeah. I noticed that too, Beth. I think we can probably add a line or two there. It is spelled out in the B. The attachment B, the children's waiver and SED waiver are also, that the overnight health and safety is also covered by those waivers as well, but we can refine that language in the A if it provides a little more clarification. Of course. Okay, I'm going to read. I'm sorry, I should have read Beth's question out loud. I just responded to it. Beth was asking about the T2027 overnight health and safety code. We didn't actually list in the attachment A that that's a covered service under children's and SED waiver. She was asking if we would do that, and my answer is yeah, I think we can do that, just to make it consistent with the attachment B and make sure there's no confusion about that. So no problem there. Next question. Given the ongoing staff shortage situation and the uncertainty of the continuity of state's pay, enhancement hazard pay, in order for us to budget properly, I wonder if providers may receive a 30-day notice of any rate changes and reductions. Yeah, the contract specifies that we are required to give you advance notice of any changes related to that. If it's a situation where the state is passing through additional funds, I mean, we can only provide as much notice as we're given from the state, I think. So, if there's more specifics about that, we would probably need to have someone from Budget and Finance chime in if they have more insight than I do.
Adam, this is Anya. I just want to agree with what you said. We certainly provide as much information as early as we have it. Unfortunately, we don't always get it within 30 days. So the intent with that language is really to be about us changing the rates that are the standard rates, and beyond that, we promise to inform you as fast as we know if and when anything is changing from the state's perspective.
Thanks, Anya. I appreciate the clarification. Yeah. Okay. Other questions? Again, just feel free to unmute if you don't feel comfortable using the chat. If you're on the phone and you're muted, I forget there's a little, you have a series of buttons. You have to push star or something, I think. Maybe someone knows.
It's *6.
*6. Thank you. Let's give another minute for people to put questions in the chat or unmute and share your questions out loud. I should also add, if you are going through the contract again and you have additional questions, please send those out to us. We are happy to respond in writing, and if there is a prolific amount of questions, we'll compile them and perhaps we can send them out with responses with the meeting minutes as well. Okay, well, I'm content to move on. We're going to cover some additional contract-related items a little bit later when we talk about Attachment D and financial reporting and things like that. I'm going to be on the call, of course, so if questions come up further down the road, please don't hesitate. I will be here and I will do my best.
Thank you, Adam.
Of course.
So this is Dina again, and I'm going to talk about the H2015 and the T2027 changes that are taking place as of 10/1. You may or may not be aware of the purpose for the change. The state felt that they were not getting accurate reporting in using the H0043 per diem. When you use a per diem, you can't tell how many hours of staffing are being provided. And they were seeing that across the PIHPs and the CMHs, the rates were wildly different. So they couldn't get a good handle on what actually was going on and really what services were being delivered. So the idea was to change to the H2015 and the T2027, both of which are unit codes. So while that is going to make things easier for the state, it kind of complicates things a little bit for providers when they are having to submit claims. So I don't know, Suzanne, if you're able to pull up our modifier chart so we could take a look at that. Thank you. If we can go to the section that says residential providers, and I'm not sure which page that's on, but it's kind of towards the end, I think. Okay, let's see. This would probably be it. Are we able to enlarge that at all? I don't know. On my screen, it looks really tiny. So
sorry, Dina, that's as large as
yeah,
I can get it.
Okay. All right. Well, I have sent this out to everyone. I sent it out via the YMLP a few days ago, and I am going to send it out again with the, oh, there you go, Suzanne. Thank you. I'm going to send it out again with the meeting minutes. But H2015 is the unit code to be used for all individuals except for those on the HAB waiver for overnight. The HAB waiver overnight is the T2027. For adults, there's an HB modifier. For children, there is no modifier. So we've got a number of modifiers. And in this list, you can see the columns. The first column is the modifiers that are entered by the core provider. So those are the codes that they will be authorizing. third column there says number of persons served modifiers submitted by residential provider. Those are the modifiers that the residential provider will have to submit at the claims level to determine how many people were served and whether or not it was 16 units or 17 or more units. So this gets a little murky, I know. So let me just talk about the 16 units first. We developed two different rates, and the reason was we had a provider that came to us and said, listen, I've got a staff who works in multiple locations in one day. Maybe they provide 2 hours of service for each person. So they're driving from site to site. They have a lot of indirect time. So while I have to pay them for 8 hours, you're not reimbursing me for 8 hours worth of CLS. So we considered that and we thought, okay, so we can increase the CLS rate to cover that indirect time. So when we say that the higher rate can be used for 16 or less units, that means that it can only be used in an instance where the staff person is working in multiple sites during the course of the day. It's not intended to be used for a staff person who only works 4 hours a day. It's if they're working in multiple sites. Then you will use the 16 modifier. If you've got a staff person who works in one place for 5 hours and in one place for 2 hours, for that 5 hours, you're going to use the regular code, the standard rate of $4.30. When they drive to the other residence where they're doing 2 hours, which is less than 4 hours, you use the 16. So I'm sure that's clear as mud. Does anyone have any questions about that, about why we did the 4 hours or less at a higher rate, and then 17 or plus units is at a standard rate? Any questions specific to that? Okay.
Tina, just to add to that,
yes.
I believe we are planning to do some examples just to help, hopefully, if people need to refer back.
Right, and actually, I think, Anya, we were planning on sending that out. We
Okay.
were sending those out to we didn't have that today. But Shannon is asking for examples. So I can provide an example. So Shannon, you've got a staff person who goes to apartment A for 2 hours. They're assisting with maybe some meal prep, some medication setup. Then they're driving to another person's apartment and they're doing another 2 hours of service. They get done there, they're driving to someone else's home to do another 2 hours of service. So in that instance, you're going to use the higher rate because you can't bill for the CLS while they're in transit from one location to another. So we're trying to cover the downtime there. So, and Shannon says, okay, so I think, Shannon, unless you have a follow-up question, I think that maybe answered your question. Is there required documentation such as mileage logs? So Brandon, no, we don't need mileage logs, but what you are going to need to have is CLS. Medicaid is always required that you document CLS in the home, what services are being provided. So you're going to always have to have your Medicaid documentation for CLS services. You want to make sure that those are available in the event that you're ever audited, either by OCHN or by the state. So how you decide to keep that documentation is up to you. We don't have a special form we're going to be sending out. You guys can determine how you want to document that. You just want to make sure that the documentation is detailed and thorough. You are welcome. Other questions? Okay, so I really think that is probably, okay, so Jennifer's asking a question. There is also significant unbillable time related to return trip after drop off at vocational programs and visits to family homes. So actually, Jennifer, if I'm not mistaken, that if you're taking someone to vocational program or taking them to their family's home, that's still CLS service. Are you saying after you drop them off then? After you drop them off. Yeah, and I don't have an answer for that right now. I don't know if that's something that, you know, we can take back and talk about, but we don't have, I really don't have a response right now. That's one of the questions that we'll put in our list to answer later. And Lisa is asking, what is the EX exception code for? The EX exception code is for any enhanced staffing situation or enhanced rate situation. So sometimes we have people who get the H2015, but they need 2-to-1 staffing. So they're going to get a higher rate. The provider will get a higher rate for the 2-to-1 staffing. So we use the EX in that situation. That has to go through specialist approval, just like any other exception would. So that would be something that would need to be coordinated through the supports coordinator or case manager before we would use that EX modifier. Does that answer your question, Lisa? Okay. Ryan, can you do some examples of an individual who receives an hour a day of adult home help along with shared CLS services and gotta expand this here, and 1-to-1 services in an unlicensed setting? So you're not going to bill for the home help. Obviously, you're not going to bill during that time, and you would document that that individual during that time was getting adult home help. You will bill for the CLS services for when they're receiving 1-to-1. You're going to use just the H2015 code. When they are having shared services, you will use one of the modifiers listed here. And it could be, you know, the UN code. It could be the UR code, the US code, depending on how many people the services are being shared with. So you might submit multiple billing in the course of a day. You might submit for an individual, you might submit billing for 1-to-1 staffing for CLS, the shared staffing for CLS, and then if they're HAB waiver, you'd even do the T2027 for that portion of the 24-hour period. Does that make sense, Ryan? Is that what you're looking for? Okay, good. Let me see. What Jennifer's asking, what will happen if a change in schedule causes the residential provider to have too many units authorized of one ratio of service and not enough of the needed one? So what we've done is we built in a 5% variance because we know that there's a good likelihood that that's going to happen at some point. If it's a major difference, if a person goes, you know, long-term into the hospital, you know, a roommate goes long-term into the hospital and this person is now 1-to-1, then you would want to consult with your support coordinator or case manager to have those authorizations modified. But I think with just kind of like the regular day-to-day changes that occur, the variance that we've built in, I think is going to cover that. It won't have to keep going through UM. Is that good, Jennifer?
So this is Anya. I just want to clarify something, that we are not, the intent is not to authorize at the modifier level. And at least I think that was the question. It wasn't the overall authorization. It was more the shift between the modifiers.
Oh, thank you, Anya. That is correct, because the provider will be able to manage that. The case manager is going to just authorize the H2015, and then you guys will be able to manage the shared and the independent, you know, CLS services. So that would be at the billing level. Thank you, Anya. I appreciate that. Pam, is the document we were looking at on screen right now available for us to download and save? So Pam, I did send this out a few days ago via the YMLP. I'm also going to send it out with the meeting minutes again. I don't think you can download and save it from this screen, but I'll make sure that you do get a copy. I'll make sure everyone gets a copy. And then Amy asks, are the modifiers listed on their new authorizations when they are rolled out? So again, the modifiers that in this chart, it will tell you there's a page that says the core providers, and it's the modifiers that the core providers have already entered. And you can see it here too in the second code, modifiers submitted on authorization by core provider. These are the modifiers that the core provider enters. It's just the HK for HAB waiver and the exception, and then the combination of the two. The remainder of the modifiers would be entered by the provider when the claims are being submitted. Does that answer your question, Amy? Okay, and then Mike is asking if we can speak after the meeting, and Anya said, yep, we can certainly help you if you can just email the finance inbox, and she's got the email in the chat. And Jillian responded as well. Okay, other questions? Not seeing any other questions at this time. I'll give you a second. Of course, any questions that you have, you know, after the meeting, you can certainly always contact us and we can help with that. I'm just typing my email address in here. So if you think of anything, you can send it to me. Also, any questions can go to the finance inbox, and Anya's team can help answer those as well. So if there's nothing else, I think we can move on then to our next agenda item. So up next, we have Victoria Vesichanski. Victoria is the cost and utilization analyst on the finance team, and she has, looks like, a number of finance updates for us. So Victoria? Victoria, you may be muted. Okay. Victoria may be having some technical difficulties, perhaps. So I know our next item is Jean, and I know Jean's not on the call. Jean is attending a ORR conference, and she will not be on the call till 10:30. So Charlotte, are you ready to present?
Dina, worst case scenario, I can try to wing it if necessary.
Okay, well,
I'm
let's
ready.
see. Yeah,
I'm ready.
Okay,
Yeah,
Charlotte?
sorry, I was
All
just
right.
turning in my video. So.
Okay. All right, Charlotte, I'm going to hand it off to you then. Charlotte has some HCBS updates for us. Thank you, Charlotte.
Yeah, no problem. Hi, everybody. I'm Charlotte Rowe. I'm a quality analyst and working on the home and community-based services role. And I just kind of wanted to provide a quick update that we are, so two things. One is that we're wrapping up B waiver, which is now the 1915 I waiver compliance work. And if you're one of the providers who there's some outstanding audit items needed, I have most likely contacted you multiple times. So if you have received an email from me, I've gotten a few providers who have not been able to open encrypted emails or something of that nature. Please let me know, and I can put my phone number and email in the chat. Feel free to call or email me. The second thing is that there was another survey completed for heirs from the 2017 HCBS survey, and then provisionally approved providers since 2017. So that list was just, that updated list was just sent to me by DDI, who administered the survey. DDI is the Developmental Disabilities Institute, who the state of Michigan has contracted with to complete these surveys. So I'm going through that list right now, but I don't expect follow-up for that quite yet. But if, again, if I have sent you emails or called you, please pay attention to that, because we do have a deadline with the state of the end of the month. And that's all I have.
All right. Any questions for Charlotte? Okay. And I am seeing none. However, I am going to put Charlotte's email address in the chat also if you have questions. Oh, and Kelly's asking for Charlotte. Oh, and Charlotte beat me to it. Okay, we're all good. Charlotte has her phone number and her email address in the chat if you need it. So Victoria, I believe, is ready to present. So we're going to go back to the finance section now. And Victoria, are you there?
I am. I am so sorry. For whatever reason, Teams decided to sign me out at the worst possible moment. So I apologize
Teams does
for the
have a mind of
technical
its own.
It really does. Well, thank you so much, Dina. Good morning, everyone. My name is Victoria Vysochansky, and today we will be going over just a few finance updates as we wrap up the fiscal year and transition into fiscal year 2021. Can we go to the next slide, please? Thank you. So with regards to reimbursement, with the use of a new automated process, we've been able to more rapidly and effectively provide reimbursement of costs incurred as reported in the FSR much more quickly. All outstanding reimbursement of costs incurred as reported in the FSRs submitted through August 26th were paid September 3rd. If you did not receive reimbursement on September 3rd, it's likely for one of the following reasons. Either your cost reimbursement contract has not yet been signed. We only have a few providers that have not yet signed their contract, but if you did not receive reimbursement on September 3rd, please check and make sure that your contract has been signed. It may also be because your FSRs had not yet been submitted via the Attachment D Smartsheet prior to August 26th, or the original FSR template was used instead of the revised FSR template. So the purpose of the revised FSR template is to separate additional costs incurred for reimbursement in column G. That column is called additional costs incurred, and that is the column that I referred to determine the amount of reimbursement that you are requesting. So completion of this revised template is mandatory to receive reimbursement of allowable costs incurred proportional to OCHN business under the cost reimbursement contract. So I've listed some reminders down here, for our providers. So again, the revised FSR template must be used to receive reimbursement. All allowable costs incurred proportional to OCHN business must be reported in column G. That column is called additional cost incurred. So please make sure that you're using the correct template. And one frequently asked question that I receive is with regards to the premium pay enhancement. So some may have been under the impression that OCHN would do a distribution similar to the DCW distributions that we had done previously. However, since we don't know how much reimbursement is needed, now that we've transitioned over to the cost reimbursement contract, you will have to report the $224 per hour premium pay enhancement on the FSR directly, and that would be under the staffing cost row of the FSR under expenditures, and that total would be listed again in column G. So that will be the column that I will refer to determine the amount of reimbursement needed for all allowable costs incurred proportional to OCHN business, and that is where you would report the $224 per hour premium pay enhancement. So going forward, now that we have transitioned over into this new automated process, reimbursements will be made monthly going forward. So since the last payment date was September 3rd, the next date for distribution of reimbursements will be October 1st. So FSRs must be submitted by September 23rd to receive payment on October 1st. If you are behind, this is an opportunity for you to get caught up on any outstanding FSRs, since I will be processing reconsiderations for anything that has not yet been paid. So please feel free to go back to March if necessary and submit all outstanding FSRs by the 23rd to receive all outstanding reimbursements by October 1st. So then going forward, the next reimbursement distribution date would be 4 weeks later. So please keep this timeline in mind when you are submitting FSRs, and that is it for the reimbursement update. Can we please go to the next slide? So with regards to the FY20 financial status reports, this slide will look very similar to the one from our last quarterly meeting, but I just wanted to provide a few reminders and let you know where you guys should be at per the attachment D deadlines. So FSRs for October 2019 through July 2020 should be completed and submitted via the attachment D Smartsheet at this time. Please also keep in mind that the August FSR is due on September 20th, and you must also keep in mind that September 23rd date for any FSRs that have not yet been submitted for which you are going to request reimbursement of costs incurred. So for the period from October 2019 through September 2020, FSRs would be completed via the original FSR template that was distributed at the beginning of the fiscal year. However, as we had transitioned to the cost reimbursement contract beginning March 2020, FSRs must be submitted via the revised FSR template and must include all required breakdowns and details. What that means is it's important that you also list, for example, we have a row called Other. It's important that you list what those other costs that you are reporting and requesting reimbursement for on the FSR. You must list those at the bottom of the FSR under Notes so that I know what we are reimbursing you for. So while we don't request documentation at the time that FSRs are submitted, you must have documentation to support expenditures listed in the additional cost incurred column for reimbursement should OCHN and/or MDHHS request it. So please have that documentation available should we need it, but we will not be requesting it at the time that FSRs are submitted. Next slide, please. So for FY20 quarterly financial statements, this is just another reminder that at this time, the first, second, and third quarter financial statements should be completed. They must include your organization's balance sheet, your income statement, also called profit and loss statement or revenue versus expenditure report, and the statement of cash flows. All three documents must be submitted every quarter. And the statements must be prepared on an accrual basis and are subject to generally accepted accounting principles. They should include figures for the entire organization, not just OCHN business like the FSRs, and providers may use any software or format. So we do not have a specific template. You just must provide your entire organization's financial statements every quarter. This will also continue into FY21, so there will be no changes surrounding the quarterly financial statement reporting. So this slide is really primarily surrounding the final FY20 FSR template, but I did also want to give you a heads up with regards to the FY21 financial status report and what's to be expected going forward. So for the end of the fiscal year, since we know that this fiscal year was a little bit unusual, a new final FSR FY20 FSR template will be distributed the first week of October. We require a preliminary September FSR due October 31st and a final September FSR due November 15th. Now the difference between those two is a FSR is due on the 31st of October for the entire period or the entire fiscal year. However, we do understand that sometimes some changes will be required. Let's say you did some late billing and you need to increase your revenues, or you forgot some expenditures for September. So we do have a 15-day period where you can make changes to the FSR and submit a revised one if necessary. So if there are no changes between October 31st and November 15th, you can just reattach the preliminary FSR and make that your final FSR. If you have any questions with regards to the final FSR, you're more than welcome to reach out to me via email directly, or you may also email the finance inbox, and I'd be happy to answer any questions that you have surrounding really any of this, any questions with regards to financial reporting. So for the final FSR, it will contain 2 tabs. So it will look much different from last fiscal year. So the first tab will request revenue and expenditures for the period of October 2019 through February 2020. And then there will be a separate tab where you will report revenues and expenditures for March 2020 through September 2020. The reason for that is because those 2 periods will be cost settled separately and will be treated differently. So it's very important that revenues and expenditures are separated into those 2 periods so that we know how to appropriately cost settle at year end. Additionally, we will also require that providers complete a DCW survey. It will look nearly identical to that was submitted last year. And the purpose of this survey will be for us to compile the information that we need with regards to hours of direct care for which the $2.24 per hour premium wage enhancement was distributed. And it will also serve as as support for distributions made for unlicensed settings for the $1.25 in fiscal year 20. So that completion of that survey will be mandatory and will be distributed the first week of October as well. Next slide, please. So all of this will look very familiar to last fiscal year, but I wanted to give you guys some updates or some reminders with regards to claim submissions now that we are transitioning into FY21. So the deadline for submitting FY20 claims is November 15th, 2020. This will be a hard deadline, so you must make sure to submit all outstanding FY20 claims by that date, as we will not be able to accept claims after that date. FY20 and FY21 claims must be submitted via separate batches. So this was a requirement last year, and I think the majority of providers did a really wonderful job of keeping those claims separate. But just as an example, if you are submitting claims for September 15th through October 15th, you must submit one batch for September 15th through September 30th, and then in a separate batch, submit the claims for service dates October 1st through October 15th. So it's very important that you keep those separate so that we can ensure that our financial statements are as accurate as possible. The FY21 payment schedule has been finalized and is actually on the next slide. So if we can go to the next slide, I can give you guys some things to look for. So it will look very similar to last fiscal year. Just a few things to be mindful of is, of course, the holiday pay dates. So we do have the Christmas and Thanksgiving holidays to be mindful of. So that first bullet addresses the deadlines for submitting claims so that you are ensured payment on the dates listed. Additionally, to ensure timely payments, claims must be submitted by the Friday before the scheduled payment date. So for example, if the payment date is October 15th, all claims must be submitted by the Friday before that date, which would be October 9th. Per contractual agreement, OCHN reserves the right to pay within 30 days of claim submission, and scheduled payment date may be subject to change. So these are just some things to be mindful of. This, if it has not yet been distributed, will be distributed Either, I apologize, Dina, I don't know what the plan is, but it will likely be distributed with the meeting minutes or separately.
Yeah, Victoria, it went out a few days ago when it was received, and then it's going to
Perfect.
go out with the meeting minutes as well. Yeah, thank you.
Wonderful, thank you. I should have touched base with you prior to the meeting, but I appreciate you letting everybody know. So those are all of the updates. Oh, go ahead, Dina.
I was just going to say, we have some questions coming in.
Sure.
Can I go ahead with questions for you? Okay, so first of all, just a comment from Shannon Williams. Shannon is Advocates for Self-Determination and Pathways. She's just asking if you can touch base with her after the meeting.
Absolutely.
And that's
yes.
regarding FSR. Okay, and then we had a question, is this presentation being recorded? The answer is yes, and I will send out the link along with the PowerPoint and all of the attachments that you've seen today. Those will go out with the meeting minutes. So I'll send those out to the network. And then we've got a question here from Becky. Should revenue received from the column G be accrued to the correct month, even though the FSRs have already been submitted? I just want to make sure I am accounting for the column G revenue correctly.
So I may need a little bit of clarification on that one, but it sounds like you are requesting, I know that some providers, if they had not reported revenues in the appropriate month and I had already approved the FSR, they simply reported it on the next FSR and made a note at the bottom of the FSR that it's for the time period, let's say from March through June, and added it to their July FSR. So that is acceptable if FSRs had already been approved by that time. If I failed to answer your question, please let me know and I'd be happy to answer your question more appropriately. I apologize if I misunderstood.
Becky, if that doesn't answer your question, you can unmute and maybe just speak directly with Victoria. It might be easier. Okay, I'm not seeing a response from Becky. Becky, let us know if that answered your question or not. And then I'm going to move on to the question from John. Did the 9-3 reimbursement include the tablet reimbursement from March and April?
So if it was reported on your FSR prior to August 26th, then yes, all additional costs incurred as reported in column G of your FSR would have been reimbursed on September 3rd.
And then the next question is a follow-up to the question Becky asked. Excuse me, is if the FSR date was later than, excuse me, I'm sorry. If the FSR date was later than the 20th of the following month, this would help some of those accruing revenue issues.
Understood. So that is something that I'd be happy to discuss with my team to see if we have any flexibility with that. But I believe that per the attachment D, the deadline is generally that the 20th of the following month is when the FSRs are due. I know some providers will sometimes submit their FSRs a week late, a couple weeks late for this particular reason. And we do try to be very flexible when it comes to that deadline. However, now that we are providing these reimbursements, you do have to be mindful of the deadlines for submitting FSRs so that you receive the reimbursement the following week. So if you would like to touch base with that a little bit more, I am more than happy to discuss that with you separately, either via email, or you can reach out to finance@oaklandchn.org if you would like to talk about those deadlines a little bit more.
Any other questions? I'm not seeing any in the chat. Jillian has added the finance inbox email address for any questions to Victoria or her team. Other questions?
Thank you, everyone.
Thanks, Victoria. All right, so Tricia, are you ready to give your update? I'm going to give Gina a few more minutes.
I'm ready.
Okay, so Tricia Zazumbo, the director of our training department, is going to provide a training update.
All right, good morning, everyone. Just again to introduce myself, I am the Director of Training here at OCHN. For our direct support professional training, majority of you know that we do contract with TTI and MORT to provide those trainings. So I have a couple updates from those organizations. TTI, their med demos, their medication demonstrations are up and running. There are a few people who had taken the initial first class that haven't scheduled to come in for their in-person demo. So please ensure that your staff that have done that are taking that second follow-up course that we weren't able to do prior due to COVID, so that they are complete on their training. MORC has some upcoming webinar opportunities. They are launching a process for virtual medication and transcription skill assessments, as well as some train the trainer webinars for health skill assessments. So they will be sending out announcements for that within the next week or so. We are continuing to do our new hire rights training via live webinar. We will be continuing that through end of the year. A lot of the questions or issues that arise from there are questions that are in our frequently asked questions in our guidance document. So I'm going to go ahead and put that in the chat for each provider. This was sent out before. It's also linked on our website and is sent out to each training participant every training. So just make sure that you read that document, that you're asking your staff to read that when it is sent to them. We are noticing that some of our emails, especially with Gmail and Yahoo emails, are going to their junk or spam. So make sure to have them look there first. We get a lot of calls that people can't find their certificates or don't have the logins, and most of the time it is in their junk or spam. Or it was sent to an email that maybe had a misspelling in it. So making sure that those that we're checking the spelling on that, and for when your staff are registering and when they're completing the test at the end to get their certificate. Certificates are being emailed within 1 business day as long as they are passing that test. I see a comment from Kelly. So Kelly, right now we are doing virtual through end of the year at this point. And we won't be doing any in-person. Our building is closed. We have canceled all in-person trainings until January. So we're just keeping an eye on the situation, and we want to make sure that it's going to be the safest possible for our staff and for yours as well. So right now, virtual is working out well, and so we're going to continue to do that. And then lastly, we have started up in September our virtual group home training. So prior, you guys were getting visits from our group home trainers. So you probably met Amy, Amit, or Rachel. And obviously right now we are not coming into the homes to do those trainings, but we are offering them virtual. So you may have received a call from one of my staff, Cheryl, asking about internet connection and if you're interested in having these virtual trainings. So for the individuals that we serve, we're doing the dignity and respect. It's probably about a 30-minute training where our trainers will get on and be able to interact with the individuals that we serve and talk about dignity and respect. So we're doing a handful of those a month, about 8, I believe, and we're just doing them 1 home at a time. So it's very, very personalized and being able to talk to just the individuals that you serve. So if that's something that you are interested in, or if you haven't received a call regarding that, I will put my email in there, and I will make sure that Cheryl reaches out. So those are my training updates. I'm going to go ahead and put that rights guidance document in the chat for you to download. Again, it is linked on our website, as well as sent out to every training person prior to their training. And then thank you, Jillian, for putting my email in there.
Thank you, Tricia.
Hopefully I wasn't
Jean?
too quick for Jean.
No, I know. Well, Jean, are you on the call? Okay. That's okay. She may have gotten held up. I can go ahead and kind of present what Jean was going to present. So I can't answer any of the technical questions that you might have that, you know, really need to be answered by Jean. But the issue is this. So Jean and her team are receiving a lot of rights complaints from people who want to return to vocational programs but are being told by their residential providers that they cannot do so. So that there were some executive orders that put in place the ability for the residential providers to keep people home. Those executive orders have expired. So residential providers cannot prevent people from returning to day program if they choose to do so. And that needs to be obviously managed through the individual plan of service with the individual served and their family or guardian or natural supports, and work through with the residential provider as well. But the residential provider cannot make that choice. They can't make that decision. Unless there's another executive order that says that can happen, it cannot, and it would be a rights violation. So are there any questions about that? I mean, we might be able to at least, if we can't answer them, we can forward them to Jean and we can get you an answer. No questions or comments? I know this is a difficult one too, because, you know, I'm getting feedback that people are short-staffed and they really don't even have the staff to maybe transport two people to work, and they're concerned about people going into group settings and then possibly, you know, getting exposed to COVID and then bringing it home. I mean, I understand that there are a lot of issues with that, but until there is an executive order or some sort of guidance from the health department, the residential providers would have to comply with recipient rights and allow people to go to work if they choose to. Chastity is asking if all programs are open at this time, and I'm assuming you're referring to the vocational programs, and the answer is no. They're not all opened at this time. I'm probably not the best person to answer that question. Sally, are you on the call that maybe you can address the vocational programs being opened?
Yes, many are open at this time at a limited capacity, but there are some that aren't open yet. I know many have done soft openings at this point, so it would just be dependent on the provider.
Thank you, Sally.
Yep.
So Jennifer is commenting, we have not prevented anyone from returning, but I am wondering about potential rights complaints from individuals who choose not to return but feel that their safety is being put at risk by housemates returning. Any insights on this possibility? So that, you know, I'm not going to attempt to answer that. I would defer to Jean on that question, and I will make sure that that question gets answered in the meeting minutes. I will forward that to her and have her answer.
Jean.
Oh, good, Jean. Okay.
I apologize.
All right, good.
I'm participating in the recipient rights conference, and so my session just got over.
Well, thank you for joining us. So I did kind of give an overview of the issue with the return to vocational programs. And then, so I don't know if you heard Jennifer's question.
No, I did not. I just did.
Okay, so I gave the overview, and Jennifer says, we have not prevented anyone from returning, but I'm wondering about potential rights complaints from individuals who choose not to return but feel that their safety is being put at risk by housemates returning. Do you have any?
To the best of my knowledge, we have not received any complaints like that yet. I'm not saying we're not going to, but we haven't received any. I don't know right off the cuff how that would be processed. I'd have to talk to my rights specialist.
Okay, thank you, Jean. And next question. We can request any hospitals to rapid COVID before returning home, or is that against their rights?
Can you repeat that?
Yeah, I can kind of rephrase it. I think Kelly is asking if the homes can request individuals to do a rapid COVID test before the individual can return home from the hospital, or is that against their rights? Kelly, correct me if I'm wrong, but.
The understanding that I have right now is that COVID testing cannot be demanded. It can be requested, but it cannot be demanded.
Okay. And then I have another question. This came to me prior to the meeting from a provider who was asking, are the staff in the homes required to wear masks while they are working with individuals? And if they do not wear masks, is that considered a rights violation?
We are expected to maintain the safety of the individuals. My immediate response to that is, if the employer has safety mechanisms put in place, then the staff are expected to abide by those. So for example, OCHN has an expectation that when I walk out of my office, I will be wearing a mask. So therefore, and that has been put in writing, so therefore I am held accountable to that. So the same thing applies to other employers. All right?
Okay. Yes, thank you.
We,
Brandon,
in the rights office, we look at standards. The standards can and often are the employer's actual policies themselves that the staff are not upholding and that the administration's not upholding with the staff.
Okay. Let's see. So Brandon just sent he sent us some DHHS just sent a memo, and then he sent some excerpts from the memo dated August 26 regarding direct care staff using masks and face covering. And it looks like this says that they should be, but Brandon said he's going to. Brandon, if you could forward me the entire yeah, do you know what I'm referring to, Jean?
Yeah, that would be helpful. I also have them all. I apologize. I simply do not have them in front of me. All the requirements. Yeah. So we look, okay, first and foremost to what type of guidance are we being provided by external sources. So.
Okay. So, but Kita is asking, is it what does rights consider it to be? Does rights consider it to be a violation?
Not wearing masks?
Yeah.
This is one of the sort of problematic aspects of understanding rights, is that it's not really about what we think, it's about what policies, guidelines, procedures, rules, laws are in place that we can cite. So I can't give you a clear-cut answer to say rights thinks this, because it's going to be individualized based on what the state guideline is, which I do not have in front of me, or what the organization's policy is regarding masks and that. And so we don't work on what is our impression, we work on what are the legal or guideline citations that we have to guide our decision making. And so it really is a case-by-case type thing.
Okay. And then Brandon has, he said that he's forwarded me the letter that he was referring to, so I can make sure that gets out to everyone along with the meeting minutes too.
Okay, yeah.
Yep. And then
I have
we have
entire
another
file full of full of the guidelines and things like that, so that my staff
There's
draw
been so
upon
many.
all the time.
For sure.
So thank you.
And then Kelly has a comment. With all due respect, you're having individuals to go to work programs and return home from programs, hospitals, and family outings, and bringing the potential risk back to the other individuals in the staff.
Well, one of the things that I think about this is that I have a job, and I am expected to fill that job, and I look at going to programs and that in sort of the same way. All right, my family member wants to work, and she expects to be able to work, and her work site has put in place sufficient social distancing, masking, and all of those parameters that are required for the general population, has put those into effect. And so therefore, us adding a level of denial to that is problematic. I understand the challenges with people coming and going. Everybody's household has people coming and going out of it. But I think that, we're not asking individuals to go and meet up with groups of 50 people in uncontrolled environments. We're asking that people are able to implement their individual plan of service and attend a work site with social distancing and masks, because that work site has accountability too, or is getting out into the community with social distancing and masks, all right, and being able to enjoy community, things to do. I mean, the options that we have out in the community right now still remain very limited with everything being shut down. But that doesn't mean that people can't go out and enjoy walking through the park and going for rides certain places and engaging in other things that they might want to do. And, we basically have to look at what are the governor's guidelines right now regarding group size, and walking outside your door is not prohibited. And so, when we look at our individuals being kept from engaging in the activities outlined within their individual plan of service, right, we're expecting that they will be able to do that unless there is a guideline that keeps them from doing that. Right. So if somebody wanted to go and attend a gathering of some sort where people are not without masks and that's one thing. But being able to go out and do your job and go out and visit with somebody in their backyard, that's very different. It's a very different interpretation. And so, we have gotten a few rights complaints already of individuals who are being held back. And it's based on a impression that the home or provider has, as opposed to reality, which is this individual wants to go and visit with his brother. I'm just making this up, okay? That's not an actual case. Visit with his brother in his backyard, social distancing with a mask, all right, and drop off a birthday card and come back home. That's very, very different than attending a huge community event where people are just gathering and not paying any attention. So I do think it's on a case-by-case basis, but we are expecting that individuals' plans of service will be first and foremost, unless we have a guideline that tells us that that is not appropriate at this time.
Thank you, Jean. I do have 2 additional questions from Kita, and this is, I believe, going back to the wearing of the mask being a rights violation. So I'm just going to read both questions. I think they might be related.
Okay.
The first question is, if the standards vary from provider to provider, how can staff understand whether they are in violation? And then also many staff work with many providers. In addition, rights cannot vary for individuals depending on where they live. All should have the same rights, true?
Well, people do all have the same rights, all right? But, you know, part of it is that life is changing day by day right now. Well, not quite day by day anymore. I would say week by week. A couple months ago, it was day by day. Um, you know, and I agree that it would be nice if there was one, you know, one standard that applied to everybody. And I'd have to go back and actually look. I sort of joined this meeting impromptu and did not have the materials in front of me. But looking at if there are indeed, there is indeed a guideline out there regarding the expectations of staff wearing masks, and that's what will be upheld across the board. But if we don't have that, and all we have is an organizational policy that says that staff are expected to wear masks within our setting, then that's what we go with. All right. So we look first and foremost for law, policy, procedure, state, local, governor's orders, etc. But we can look at anything that that suggests a guideline, and employer policies and procedures would be that. So I agree that it needs to be consistent, but sometimes that's not as easy as it may sound.
Karen, did you want to unmute and make a comment about workshops? Karen, your audio is not coming through. Karen?
Hang on one second.
Oh, I can hear you.
Do you want me to come back to you?
Can you hear me now?
Yes.
Yes, we can hear you now.
Okay, sorry about that. You know, I just wanted to say I was as concerned about anybody when people started wanting to return to work and guardians were insisting that they were going to return to work. You know, I have people that have been working at Kroger pretty much throughout the pandemic. I have people at Hollywood Market, and we have people now returning to day programs. And so far, we haven't had a problem with, you know, COVID, because I think the day programs have really put a lot of good protocols in place, and they're doing the soft openings, as someone mentioned. I mean, the data, there is no data right now that says people in the day programs that there's an outbreak of COVID. You know, the universities, we're seeing it, other locations, you know, they're reporting huge numbers, but of course they have more people at the university settings. But, you know, we have 36 locations throughout Macomb and Oakland counties, and I have a PR, a personal residence in Macomb County that's literally, we're going to probably have to split up in the next couple months because the parents are just up in arms. They're, you know, they're fighting. Nobody will compromise. One mom says, my son is absolutely going back to day program. Two other families say, there's no way, split this home up. So, I mean, it's really causing a lot of controversy and stress. But I mean, I just wanted to say on a positive note, not that it couldn't change, but so far, we've not had issues with anybody being exposed to COVID. I think the day programs have done a really good job. So that's just my input. I'm having more problems with the parents and guardians than I am with people bringing COVID back into the home. So that, you know, that's just our experience so far. And I'm, you know, very pleased that that's been the case.
Thank you for sharing, Karen.
Oh, you're welcome. Thank you.
Kelly, I know you had your hand up for a while. Did you still want to make a comment?
Yes, please. I just kind of wanted to, can you hear me?
Yes.
Okay. I just wanted to kind of clarify what my comment was. I think that the work programs and the day programs and job opportunities and that kind of thing it's a wonderful thing. And I want to also agree with Karen. I think that they have done an amazing job of just being as protective as everybody else is. So that wasn't my concern. My concern is more of the hospitals, because obviously I deal with such high behavioral individuals that we got a lot of in and out of hospitals. And to say that the hospital can't, I think that it's only fair that we have them tested, because they're in and out so often, and there are so many people in the hospitals, for crying out loud. I was there just the other day, and there was probably 30 people in the hallway, for crying out loud. And I just want to make sure that we've had 0 cases. So I want to make sure that the hospitals are doing what they are supposed to be doing too. But when you've got 20, 30 people in the hallway, you don't know what they have. So I'm willing to do a rapid COVID just to get them home. Just, I mean, that takes what, 20 minutes, 30 minutes, so that they can come home. My fear is that if we don't do that, if we don't say to the hospitals, this must be done, and they potentially are exposed, we're exposing, in my case, multiple other individuals. And that's where my concern was. So if it didn't kind of come out the way I wanted it to and when I made the comment, that's why I raised my hand. So my biggest concern is obviously the hospitals. I think that the work programs are amazing, and I can't, I'm super excited that they're going back to work and getting back to a daily type of routine. We are still maintaining all of the health and safety that we did from day one of when the COVID first started, temperatures, things of that nature. But
Hey, Kelly.
Yep.
It's Laura Smith from ResCare. How are you doing today?
I'm good, Laura. How are you?
Good, thanks. Hey, I agree with you, but you know that when you send a client to the hospital, they're going to test them. They're going to test them before they ever go in that hospital, and based on what their test results are is where they're placing that person. So I disagree that we don't have the right to have that same right. I agree with what you're saying. They should be tested when they come back out, but they're tested when they go in. I don't have every single person that I've had been admitted they've been able to tell me that they had a test when they were admitted.
Okay. And we have, I've required the hospitals to do it as we're going, but my understanding from what Jean said that we can't do that. We can request it, but we can't.
But how can we not do it if they're already doing it? They're mandating it the minute you walk into the hospital. So if that's the case, then the hospital's violating their rights.
I understand, and I totally agree with that. Yeah. But my concern is,
and there is if you look at, for example, the governor's guidelines, you will see that there are differentiated allowances based on settings.
Right.
And again, I don't have those in front of me. It's a small booklet at this point of things, but the latest that I have is that you can request, but you cannot demand that somebody have, just like nobody can demand of me or of you to have a COVID test done.
But our individuals are fine with it. That's not, my problem is with the hospitals, because I know I've gone into the hospital myself with an individual now that they're letting you, like say Troy Beaumont, you must go in there with them. Some hospitals aren't letting you in, some are. So I've gone in there myself. How do they know I don't have it? So they're not testing me. They may test the individual, but how do they know I don't have it? I mean, I don't, but that's not the point. The point is I just want to make sure that me on my end saying to the hospital, you must COVID test this individual, because I've never had an individual that has denied it or not wanted it. And I want to make sure that I'm okay by saying to the hospital, I want this rapid COVID test, and then of course it can come home. It just takes minutes. It's minutes.
Once again, you can request, all right, but you can't demand. We cannot demand that individuals subject themselves.
But the individual's not denying.
So you just have to be careful on how that comes out.
How do I approach the hospital? I mean, because none of my individuals have ever said, no, I don't want the COVID test. They are, whenever I've had anybody being discharged, they're like, yes, I'm totally fine with that. Not had one individual that has denied it or not wanted it. It's the hospitals I'm having a problem with. So how do I approach the hospital? By saying, look, my individual wants to be COVID tested before he comes home or she comes home, and I have to protect the other people in the home as well. Any suggestions?
No, I don't have any right at the second, but yeah, I think it's a good thought line.
Yeah, if anybody has any suggestions, if they could email me. The only real hospital I'm having a difficult time with is Troy Beaumont. Everybody else is pretty much doing the COVID test. Troy Beaumont's giving us heck. So
Interesting.
how about it? Yeah.
Okay.
So,
Right. So
I just wanted to clarify it. I didn't mean to make it sound like I didn't want them to go back to program, because I think it's great. I think they're doing a great job, and they're definitely following the health and safety guidelines.
And once again, I have not gone to every place, but I've gone to a number of places, and I've been very impressed. They are, just like my employer, they are going above and beyond, trying to make sure that they are in compliance with, the standards that are out there regarding protecting individuals, with social distancing, with masks, with cleaning, safety, and all of that. So it's been, I have a family member in the system, and I understand what the issues that people are facing.
Yes, and I find that too. So I absolutely agree with that. What Karen had said earlier and that's where I'm having the hitting the brick wall is again more the family members going, oh well, if he's going to work program, I don't want my individual exposed to that. So you need to move him into a home where they're not going.
That's problematic. I can see that. Yeah.
So if anybody has any suggestions for that one, either email me, please. Thank you.
Jean, it's 11 o'clock and we still have a number of questions. So I want to move on to the next question if we could. Karen, I'm sorry. Did you have a comment, Karen?
Thanks, Jean.
Yeah.
Just very quickly, thank you. Can you hear me?
Yes.
Yes.
Okay, great. I just wanted to say, Royal Oak Beaumont, I have a longtime friend who's been a nurse at Royal Oak Beaumont, and I do agree with you that I'm more concerned about the hospitals and the day programs. My friend and 4 other healthcare workers, 5 total, are extremely sick with COVID because COVID-19, because a patient had it who wasn't tested, and they were unaware, or it was too late by the time he showed symptoms. And 5 of them, she's going to be off work for an extended period. I mean, it's hit really hard. So I just want to say I agree with you. And I think that's an example you could use, that Royal Oak Beaumont had 5 staff infected by 1 patient. So it's still being spread in the hospitals for sure.
Thank you, Karen. So, Jean, we've got 2 more questions from Kita. Actually, I think it's 1. It's, will each POS activity be assessed by case managers for acceptability vis-a-vis COVID?
That's a good question. I don't know. Are you saying, are each supports coordinators looking at, I'm sorry, can you repeat the question?
Sure. Will each place of service activity be assessed by case managers for acceptability vis-a-vis COVID?
You know what? I have no jurisdiction in that area. It's an intriguing question. Thinking about looking at individuals' IPOSs, and are there things in the IPOS that might not be congruent with COVID? However, I also think that the guidelines regarding COVID are moving targets. But I have, I don't have the jurisdiction to tell case managers and supports coordinators you have to review an IPOS, every IPOS that you have your name on. But that might be something that, Gina, I don't know if you want to have a conversation about that.
Kita, did you want to unmute yourself and respond?
Yes. So my concern is really that if there is a moving target, then it's the staff, the DCWs, who are going to be put in the position of having to make a determination of whether a particular IPOS activity is COVID safe. And, in our staff shortage, we cannot afford to have staff pulled off work because they've made a decision with which recipients' rights doesn't agree.
Well, okay, one of the things I just heard you say that they would make the decision. That is not a decision that they should be making. All right. And IPOS has general global guidelines regarding community access, regarding the types of the things that the individuals want to do, the things that the programs or services that they are supposed to receive and attend. So, choosing not to follow the IPOS is not a direct support professional decision. And that should be something that within each home that you staff and the home manager and the administrators should be aware of what is in the IPOS. And if there are any issues, okay, that those be taken back through the correct circuits to the sports coordinator, case manager, etc., for review. But it should not be a decision. You cannot randomly choose to not implement the IPOS.
Agreed.
The IPOS is an agreement.
Yes.
All right, that we have. So, for example, most IPOSs do not have the level of detail for community access saying that, John will attend a Tigers game every Saturday morning or every Saturday afternoon as available. All right, we know that we can't do Tigers games now, but that's usually not what IPOSs get at. They basically are saying that individuals should be accessing the community, all right, and then that becomes, what do people want to do that afternoon, on Saturday afternoon or Sunday afternoon? What do they want to do? All right, but choosing to implement sections of the IPOS and not choosing it is really not that level of staff's decision. All right, that is something that IPOS belongs to the individual getting the services. And so people cannot randomly make decisions not to do it.
No, I am wholeheartedly in favor of the theory that we're promoting, and I write the standards, and I know how difficult it is to identify specific scenarios that may arise, but I'm thinking of work on the ground as it transpires, and so it seems fine for an individual to attend a family backyard barbecue. A staff drives that individual to the backyard barbecue and discovers that the barbecue has been moved inside and no one is wearing a mask.
Yeah.
Does the staff simply leave the person? I mean, how do we handle that?
You start having discussions with individuals about safety and things. We're not going to be able to problem solve through every single instance of things that are going to happen.
Exactly.
I realize they're out there happening.
If we could have some scenarios, that would be really helpful in terms of explaining to people how these guidelines might arise as they do their work. Just a few scenarios to give people some sense of how to analyze and apply these guidelines on a day-to-day basis, because nothing ever transpires as we would hope when we write our standards.
Yes, and we certainly see that, when we're talking about rights, ORR looking into things, the vast majority of the time, it's something that was unexpected that happened. It's not a common thing. It's usually something that popped up and then it became a issue. So
do you think some scenarios could be included with the guidelines?
I certainly could come up with some scenarios. Actually, believe it or not, I actually have some already out there that I've been using for in-service training.
If you could share them with the providers, I know that would be helpful.
Dina, I'll send them to you. Maybe you can include them with the minutes.
Sure thing. Yep.
Well,
Okay.
thank you. Thank you very much.
Yeah, that, you know, it's a good suggestion. Thank you.
Jean, we've got another question from Devon. At this time, are staff required to wear the N95 mask or the non-surgical mask along with the gown, or are they just required to wear a mask with a gown or with no gown? There are a lot of orders and the requirement can be confusing.
You know what? I cannot respond to that right now because I don't have the most current order in front of me. And so I'm not even going to venture a guess in that one. All of the governor's orders are in one place on the governor's website, and then all of the DHHS orders are in one place on the DHHS website. And I tend to look at them every, you know, they get sent to me pretty regularly. And I look at every single one of them. But I can't answer that question right now because I don't know definitively what the response is to that.
Okay, Devon, we'll get back to you with an answer. We can send that out with the meeting minutes as well. And then Brandon also said that he was going to send Devon the memo from MDHHS. Yeah. So thank you, Brandon. And also he's sending that to Jennifer. Okay, so Jennifer has a question. We haven't needed to require the rapid COVID before return home. If we suggest it, the individual and family, if applicable, have supported the request and the hospital has done it. Mostly the hospital has just done it, actually. So that's just a comment to, I think, what Kelly was saying earlier.
Well, and I have to say that I have heard the same thing. I don't know what's going on at Troy Beaumont. I think that's the example that Kelly used, but I've heard that most of the hospitals are doing that. So, but I don't have any concrete evidence.
Okay. Jerry has a comment. Jerry said that she received a directive from Oakland County Health Department that anyone who is away from home for 72 hours has to be tested before they return.
Oh, that's interesting.
Mm-hmm. Jerry, do you think that's maybe that directive you could forward to me?
Mm-hmm.
And we could take a look at that because I don't think we're aware of that. So I am putting my email in the chat if you wouldn't mind forwarding. Let's see. And then Chastity, hang on, I gotta go. Whoa, okay. Going way back here. We have a lot of questions, Jean.
Okay, Dina, I do apologize. I have very limited time right now.
No problem.
I wanted to pop in and see, but how can we handle this so that I can move back to where I need to be?
Go ahead. You know what? These questions, the questions that people have submitted, we can certainly put a Q&A together. Okay. We can have you kind of go through and we'll get them some answers. We'll send those out with the meeting minutes as well, so we can make sure all these questions get answered. Yeah. Does that work for you, Jean?
Yes, I do apologize, folks. I had this half an hour that I could pop in, and that is now done, and I'm actually one of the facilitators. So I need to get back to where I'm going.
All right. Get back. Thanks very much, Jean.
Okay, take care, everybody.
Bye.
Bye-bye.
So like I said, we will get you the answers to these questions. We will compile them in writing and we'll get these out to everyone. So we have Adam, if you want to provide the reminder on the vaccinations.
Yeah, sure thing. Thanks. Thanks, Dina. So just wanted to make everybody aware briefly about a resource that is going to be available to folks. We have a provider who many of you are familiar with, CNS Healthcare. They are going to be doing a mobile vaccination clinic. We've mentioned this previously, I believe, on one of the Friday calls, and I think we sent out some information about it over YMLP. So I don't think CNS has received too many requests thus far. At least that was the update that I last heard from them. So as we approach flu season here, please do feel free to reach out to CNS. And I think, Dina, we could probably send out, I think it was like a flyer that they had shared with us. We could probably send that out again, maybe with the meeting minutes, or otherwise just send it out over YMLP. I'm expecting to be in contact with CNS Healthcare at some point in the coming weeks. So if there's any additional updates, we can pass those along as well. And I just also wanted to mention that another resource, if people are interested, would be Honor Healthcare, which is, of course, the federally qualified health center. And they have some locations in our region, and some of our core providers are well integrated with them, and some of the folks who you are supporting may already be engaged with Honor Healthcare, and so some vaccination services are available through them as well. So that's it. Just a quick reminder about that, and then we can push out some info about it as we get it.
Thanks, Adam. I think that's everything. I just want to let you know that the next provider meeting is scheduled for Thursday, January 14th from 9:30 to 11:30. That one is tentatively scheduled for the OCHN building. We'll see if we have to go back to a Teams meeting, then that's what we'll do. And I will be getting out a schedule of the provider meetings for the rest of fiscal year 21. When I send out the meeting minutes, you'll have that in your packet too. So again, I apologize that we had to cut that ORR discussion short, but we will circle back around to that. And are there any other questions or comments before we sign off today? Sarah says she likes the meetings online. Let's do this forever. Hey, if we get that feedback, I gotta admit, I like them too. So we'll see. Kelly says, me too. Anything else before we wrap up? All right. Okay. And so Jerry says, is it possible for Jean to attend Friday's meeting? Jerry, I will ask her if she is available so that we can continue this conversation. I don't know her schedule, but we'll see what she says. And Jillian, thank you, Sarah, for your feedback. All right. Thanks, everyone. Take care. Be well. Be safe. Have a good day.